So, let me introduce the program. The program that has been created by the foundation called Children and War Foundation. And it's called Teaching Recovery Techniques, abbreviated as TRT. So first about the foundation as such. The foundation has been created in former Yugoslavia after the war, and then it took part in different situations of war and or traumatic events, for example, related to earthquakes or tsunamis. So you see the list of founders of this foundation, and they continue working, and these are only the main founders, but there are also many, many more people working in it. And you see in this map that the foundation has been working in many countries which experience the situation of trauma. I must also say that the program which I'm presenting has been offered to Ukrainian audience back in 2014 when with our friends we came to Ukraine and we taught um, for the psychologists and social workers. So what should we mention here? First of all, we need to mention about the experiences which children have when they experience trauma and what are the symptoms that they have and how do we deal with them through our program. Perhaps many in this audience knows that the nature of the traumatic event plays a very important role. I must say that from my experience, well, albeit very brief experience of working with Ukrainian children who came to the UK, it's definitely true that children who survived violence have a very high level of PTSD symptoms. Children which uh, survived only sirens and staying in shelters, they have significantly less PTSD symptoms. But you also know that it depends on individual features. Children who already had some mental disorders before the war, of course, are in a worse situation now than those who didn't have them, regardless of the nature of the trauma. So, mostly, we've been working with three groups of symptoms in children. First group of symptoms is re-experiencing. They take different forms, most often in the form of flashbacks. A- And also they manifest as nightmares and they manifest in play and in drawings. The second group of symptoms is about avoidance. And the avoidance, there are two main types. First of all, it's avoiding everything which resembles the trauma. And secondly, it's it's avoiding the thoughts and feelings of the child. And there is also the third group of symptoms on excessive arousal. Most often they manifest in sleep disorders, in irritability, and being easily startled. If we think what is supporting the post-traumatic symptoms in children, most often it's about uh, children having intrusive uh, experiences and trying to avoid them. So, in the short term, it brings some improvement, but also it leads to hyper arousal, over arousal. And in the long term, it does not enable the child to process these experiences. which the child has. So the cycle loops and goes round and round. Also, we must say that there is a direct relationship between our thoughts and memories, between how we feel and what we do. It makes a triangle, which is the basis of all CBT. So, what is the program about? Our program aims, first of all, to show the children and their parents that all reactions to trauma are normal. There are no abnormal reactions, and that they are not going crazy. That's number one. I think this is one of the key elements in our work. The second part of the program is to give children skills of how to regain control over the symptoms of trauma. This program is composed of 5 sessions for children and 2 for the grown-ups. 2 first sessions are about the intrusion. One session is about over-arousal, and the last 2 sessions are on avoidance. They last 90 minutes each. We try to make them in groups, relatively small groups of children, mostly 8 years old and above, who roughly have the same intellectual developmental level. We try to have at least 2 leaders in every group. Each session lasts 90 minutes. I must say that we think that the nature of these leaders is not really important. We have also been teaching the psychologists and social workers, and I think that the profession, the occupation of the person is not that important. It's more important that the person has the skill to work with children. I would say that it's better to teach children who have lots of experience working with, to teach teachers who have lots of experience working with children than psychologists who have never worked with children. So we start with the intrusion. As in any part of the program, firstly, we deal with uh, education on the nature of the intrusion and the triggers. So, what can trigger intrusive thoughts and memories? The second thing is about giving the skills and how to cope with these intrusive thoughts and ideas. Before we start working with the intrusions, we introduce the so-called safe place technique. It can be a real or imaginary safe place. This Sunday, I conducted a clinic with children and I heard so many options of this safe place. Very often, they were about the memories. For example, very often the children were remembering the garden with bees for some reason. So as soon as we have the safe place, we are trying to ask the child to explain what the child hears, what it feels, what it senses, what it can touch, and what are the tastes associated with that safe place. So as much details as possible. There are some nuances about, and before doing this exercise, we need to understand what is a safe place. If there are people who died. Some children might have difficulties, for example, if the place is associated um, with the person who died. But overall, it works well. Also, children with a bit lower IQ, they also might have difficulties here. And for them, we use the grounding technique, trying to engage all 5 sensory modalities. So when we understand that the child has the option to go into the safe place or to ground itself, then we start working with intrusions. And the foundation is trying to enable children to regain control over the intrusions. We are working with what the child sees, with the visual flashbacks, with auditory, and so on. And we're trying to empower the child so that it would have the control instead of being scared. So we are trying to let the child to imagine that she is bigger or smaller or black and white or in color, to regain the control in all sensory modalities. This is valid for all the sensory modalities, with the objective for the child to stop being scared and to regain control, to feel control over this. The most difficult thing is to work with kinesthetic modalities. This is especially valid for children who were thrown away by a shockwave. There are some interesting nuances there, that often children pee themselves. And when we are trying to explain to these children that they are not really overly scared, it's just a natural response to a shockwave, which which applies pressure to their bladder. Another thing about the intrusions and nightmare, very often children are telling about nightmares. This Sunday, I talked to girls from Mariupol. One of them couldn't tell about the bad dream. She was just crying. And then she told her mother that the bad dream is that the Russians are coming to London and killing everybody, including her. So working with nightmares mostly is in, engaged in is about us inviting children to tell about the bad dream, and sometimes children can define the ending. There are many different techniques on how to choose the ending properly. Sometimes children can imagine themselves as a superhero, an action hero, and then after a few of these sessions, then usually the nightmares are gone.
The next session is working with arousal. So we are starting to work with children, trying to make them imagine the sort of a barometer of emotions. It's again about the psychoeducation, which plays a role, and the skills are related to relaxation and also other techniques, how to cope. Very often we start with asking children to describe the symptoms they feel. So it's always a good idea to have around a circle among children to describe these things. Then when we are aware of various symptoms that are different with different children, then we are trying to teach children several skills that might be used to cope with these symptoms. Sometimes children have no idea what the barometer or thermometer is. By the way, Ukrainian children, all of them know. British children have no idea because they're using these new no touch or electronic devices, but Ukrainian children usually had other experiences. And next, we teach children relaxation techniques with breathing techniques, physical exercise to relax the muscles. And we also are using the techniques that help manage the imagery. So they try to learn to manage their imagery. Now about avoidance. It is especially difficult to work with this part, especially with children who are highly traumatized. So we start with education, the same. So we're trying to teach children, to explain to them that children may avoid avoidance gradually. So exposure is the basis of our technique, of our treatment. We're also positing that avoidance could be right or wrong, correct or incorrect, useful or not useful. It is obvious that especially today during the war in Ukraine, in certain territories in Ukraine, there is this useful and correct avoidance where there are mines around, but also children might not understand the proper difference between the useful and unuseful avoidance. The unuseful avoidance is about avoiding things that are not objectively dangerous or threatening. Next, our guidelines include the story, a very good story about a child who had no heads for height and decided to take the ladder. So on day one, the child would step on the first level of the ladder, and it was not that scary. And then there was a second stage and the second step, and on and on. And it's about exposure. Next, this principle is used with various types of avoidance, also avoiding the recollections of things. I believe the next speaker is going to share about a very interesting case, how the child was trying to avoid what happened. Very often when they are drawing, they afraid to remember what happened, and we are encouraging them to describe and tell until the end what is depicted in these drawings, because all of these perseverances would not end up successfully. So this is the end of our program. We also have 2 sessions for parents, and they are mostly to describe how to organize the routine for children. We are talking about things that are not helping. Some parents are afraid to talk about what happened, about these experiences, not to re-traumatize children, and others are doing conversely. So these are 2 key positions. They're not useful. So when we work with parents, we're trying to explain that they should allow children to speak if they feel like, not to be afraid of that, not to stop, not to interrupt them. And also we are trying to explain to parents the things that children might have misunderstood. I have a case of a family where the child, I witnessed the mom dying, and the dad kept saying that mom was still alive. So we are trying to explain how to explain to children the truth. Another important thing is to organize and arrange the proper and correct routine for a child to feel safe. So this is briefly about our program. Here you can see the links and feel free to ask your questions.
Thank you very much for this practical presentation, and we will wait for several questions in the chat, or maybe those who want to raise a question, please raise your hand and you can ask question either in English or in Ukrainian. Are the contradictions for children? Are there any?
This is a valid question. I would say that children who are not willing to talk, who are not ready to talk about the experiences, they need to take their time. For example, the children who were raped by Russians, I think the key objective is to keep the psychologist away from them in the first stages. At least they need to be left alone so that they could understand that they are safe and that their basic needs are satisfied. There are children who are not prepared for any kind of work. You just need to leave them alone. Also, I think I should mention, so far, I have not seen any such cases, but from my previous experience, I could say that there are children with high suicidal inclinations. And therefore, any mentioning of what is happening would lead to the suicidal crisis. In my life, in my experience, I have worked with many children, but I remember children who would respond with a serious suicide attempts to any triggers, to any mentions. I remember them very well. But I think that you also need to create certain preconditions for such children to enable them to work.
Thank you. There are two questions in the chat and one hand. We have one hand. So first question is quite simple. So techniques for image control, are they TV with controller, or like, can you give examples?
In fact, as you probably know from your experiences, the visual intrusion happens most often out of all modalities, and they are mostly most scary. Children are getting scared most often. They could be very different, and they could come up in different times, and they could be caused by various triggers. Sometimes the triggers are obvious, but sometimes these are some unusual smells, aromas, sometimes rather subconscious. But Ukrainian children would very often perceive the sound of the train as the trigger. I'm not sure what the reason could be, and I have never seen this happening that often with children of other nationalities. So whenever you have these intrusions, then the key to the treatment is to empower the child, to give control to the child. The more the child works with the intrusions, you can use various techniques how to control the images. It could be the remote control from the TV that works very well, the TV on the wall, or holding the remote in the hand of a child, and also imagining in the imagination of the child. And you can do whatever with this. It could be related to anything related to colors, brightness, adjustment, whether you can see well or not, whether it's close or zooming in, out. The key to this work is the maximum exposure of the child. The more you work with the images, the better. In fact, eventually, as a result, children get bored. They stop being afraid of them. So whenever you get to that stage when they start feeling bored talking about this, that's very good.
Thank you very much. Just let one person from the audience, Yulia Mishchicha, ask her last question. And yeah, as promised, we will then switch to a second presenter, and all the unanswered questions, we can discuss them during the discussion at the end. So Yulia, if you want to
Так,
ask your
доброго
question.
вечора. Доброго вечора, пане Онисе, добрий вечір.
Good evening. So good evening. I took this program, Children in the War. I actually find myself in a situation that I am the only person as an expert in this technique. So could I really lead this group of 15 children myself? Thank you for the question, but I would not advise that. I would not recommend that, especially if there are 15 children in a group. I am certain that at least one child will have the compensation, will be bursting out into tears or feeling bad. And if you are alone, you will have to decide whether to manage this child or continue with the group. So if possible, try to avoid working alone. But then in that case, what is the number of children that you could manage alone, or should this not happen? Well, I work with one family myself, it's fine. Or just a mom or a parent, and several children, then it's easier. Then you can really help a child when you have the session with the mom. But if you have many children, then how do you do this?
And Maryna Gumeniuk, she's a neuropsychologist and clinical psychologist, and she's a head of neuropsychological center for families and children in Kiev, named PsyMed. And she will share her clinical experience. And please accept this information as a clinical issue that requires, of course, discussion among experts. So thank you, Maryna, for joining us, and please share your experience.
So I work in the PsyMed Neuropsychological Center. It's a private center and it's opened just in May. And today we work with loss therapy, with PTSD, acute response to stress, family counseling and therapy. And the main scope of our work is, it used to be neurodiagnostics and neuro correction, delayed disorder, the disorders of speech development, ADHD, preparation to school. Also have different types of testing and bioacoustical correction. Now we have more and more children who have organic symptoms and psychotrauma. So, who do we have? We have children with trauma who lost their relatives because of the war, women who lost children and relatives because of the war, also women who lost their houses, and those who came back to Kiev from abroad, and they have anxiety and panic attacks when they hear air raid sirens. Well, I want to tell you in brief about the neurophysiology of um, anxiety, because I think that working with trauma, we have to understand how it affects the brain and how the brain responds to the triggers. In order to work with anxieties, we have to know that the prefrontal cortex, the front uh, part of the brain, it processes abstract notions, objectives, different ways of behavior. It inhibits the automatic responses in the limbic system. And it's the limbic system which launches the fight or flight mode. So essentially, the prefrontal cortex inhibits the limbic system, and the fear and anxiety are there in the limbic system. And the prefrontal cortex is not about emotions, it's about precise information. So the mutual relation between the two is very important for the quality of life of the person. The prefrontal cortex controls and affects the limbic system and gets exhausted if there is multitasking. And when there are changes in activities, it regains power. And only the prefrontal cortex can show to the limbic system who's the boss. And the prefrontal cortex is forecasting, focuses, uh, and guides the actions. So in CPT, we address the prefrontal cortex. So people in anxiety have complaints that they have difficulties focusing, drawing, or reading, or writing, or watching films. And it's because the limbic system, if it wins over the prefrontal cortex, then uh, well, it's a natural response. If a person is scared due to danger, then it's very difficult to say tell yourself to calm down, even if you take pharmacological support. Anxiety does not let one think properly because, well, there are more connections in this ancient part of the brain, way more than in neurocortex, and very often it wins because, well, rational thinking rules our behavior only when we feel safe in terms of basic safety needs. So, when we are in anxiety, how does one make a choice? This is what we hear very often from the clients. In ongoing, continuous anxiety, situation of making the choice, like coming back to Ukraine or staying abroad, it's one we offer to the person to choose between the two worst consequences and to compare the two. In these cases, I engage the prefrontal cortex not to be isolated from the limbic system, but we engage the prefrontal cortex to work with the limbic system and to take the better decision. So a clinical case, a teenager, 16 years old, lost one of the parents. What are the symptoms? The teenager avoids thoughts, feelings, and conversations related to trauma, avoids activities or places which um, invoke the memories of trauma, has lower interest to previously significant activities, and is pessimistic about the future. And always, before we start therapy, we have uh, an examination, a neuropsychological or pathopsychological examination. And here are the certain criteria. I, didn't- I have not included all of them on the slide. And I wanted also to keep the privacy, but this is what I can show. Uh, we examine the neurodynamic processes, which is essentially the attention, concentration, and and rational capabilities. We see deviation and exhaustion of mental activities. The memories uh, is adequate enough. There is also the free association test when the child draws 8 drawings and invents the name for them on a sheet of paper. So here there were repetitions in the drawings. Most are military or war related, and also the associations with safety and resting. And there is also the inertness of mental activities and perseveration. So the uh, the self-esteem assessment on the rationality scale, the child assessed a 7 out of 10. In health, it's a 9 because the child feels well. And children find it difficult to recognize this state, both uh, physical and emotional. So when you ask them how are they respond with just good. And the biggest problem was exactly in this when we conduct psychotherapy. That's why I often give them a choice, a list of emotions so that the child would note which of these emotions they feel. On the happiness scale, they uh, they graded 7 because they said that, well, at least we're alive as compared to other families. It's terrible, but yeah, this is how it is. So what are the stages of the therapy process? First, establishing trust, which gives access to the traumatic content. Trauma-centered therapy, which researches the traumatic material and works with avoidance, anxiety, and alienation. It helps the client to separate from trauma and reuniting with family, friends, and the community. These are the 3 stages in the therapy process. So the question is, what do they show? The Basdaka hostility questionnaire. It shows quite a high physical aggression and irritability, which is caused by the sensation of bitterness and anger. The Spielberg-Hanin anxiety scale shows high reactive anxiety. Also, we could diagnose PTSD according to the CPSS. The unfinished sentences technique, well, you can see some of the sentences of this screen. I regret that we didn't move out to a safer place. I hope for the end of war. I would be happy if all the family members would be alive. Before the war, we were very happy, and he doesn't want to remember. He doesn't want to forget anything, and avoids trauma-related places. There's high anxiety, irritability, physical aggression, guilt, and there's also exhaustion of mental activities. We see emotional alienation and high level uh, of alertness, and this we diagnose as PTSD. Psychotherapy. So the techniques which we use for therapy. I like working with metaphors. Metaphors are related to neurobiology, so it's very close to me. For example, there's a metaphor of a dog and the owner, and it helps to explain the child how anxiety affects the behavior. We tell that the sensory modalities look like, well, they are like a dog. So if there is something that looks as a trauma, that part of the brain is barking and sends the imagery of trauma to other parts of the brain. And this makes the person sad. But there is also another part of the brain, the prefrontal cortex. Let's call it the owner of the dog. So when the whole brain works uh, as it should be, both parts, the watchdog and the owner, they work well together. So when you experience the sound or the image which reminds of the trauma, some parts of the brain they are barking, and it's like a dog without the owner. And this is needed to make sure that you're in safety when there is a danger to one's life. But now, when, well, there's no direct threat, the dog needs training. And unfortunately, uh, that child is not in a safety situation now. But we need to teach them so that they would properly act in trauma. And drawing is a very handy technique. So I draw the brain, the dog, and the owner. It's very clear for children, and they perceive this metaphor very well. And next we conduct uh, CBT exercises. So children actually follow these exercises very well. And the child is writing down which activities they are avoiding due to anxiety, fear, or arousal. And in that particular boy, he didn't want to get out of the house to meet friends, to do sports. And, well, he was avoiding by just playing computer games all the time. Well, not all the time, but sometimes. He was also helping uh, to do the chores. Also, there is another metaphor that trauma is a robber. I like it because we can personify the trauma and tell that, well, the trauma tries to rob you of some parts of your life. You can't walk down the street where the tragedy happened. So we need to recover some parts of the previous life. We need to show the trauma that they can't do that. You can't always walk the different path. We have to work with um, deep convictions uh, which formed under the effect of this trauma. It's difficult. That boy had the following convictions or assumptions that something very scary will happen. Life will never be the same. Nobody understands me. The child thinks that these convictions are true, and the child really believes them. So we need to figure out in which situation this has formed, and then we can question this up until uh, we see that this conviction hasn't been formed under trauma. So working with negative automated thoughts. Tell the child that when these thoughts come through one's mind, it affects the the whole feeling, and one needs to follow them and write them down. It's difficult because, well, paying attention to these scary thoughts is difficult. So we remind the dog metaphor to tell how it's important. This is a feature of the teenage years. Intrusive thoughts or repetitive thoughts. How do we work with them? So we have the list of negative thoughts, and then they write down opposing thoughts. This exercise is quite complete, but it's very effective.
Робота з думками, що повторюються, це
Working with the repetitive, intrusive thoughts could include the visualization. You could visualize that the thoughts are the leaves flowing along the stream of the river, but you wouldn't have to rush and follow them, but you just watch them flowing, passing by. And also, it's important to take down the advantages and disadvantages of these intrusive thoughts. There is another exercise which I really like. It's related to art therapy. When a child needs to make 5 drawings depicting themselves and their life. This is a series of drawings in the beginning and in the end of the therapy. And then we try to match and compare them, and you can see the outcomes of the therapy. So the first drawing I asked them to draw is the self-portrait. You can see one head depicted, and then the child needs to draw the environment, there's space. This drawing shows how the child perceives the world around, the relations to others. The third one is the story of life, my previous background, my future goals, my life path. This could be like a scheme or a chart. Then another drawing, me and my family. It shows the actual situation in the family and who is doing what. And the fifth drawing is the second self-portrait after the series of drawings. And it's important to see whether the child sees themselves the same way. And it highlights the transformation, if any. And we can see what type of transformation has taken place. And this is the illustration when the child would first draw only one head with distinctly marked eyes, which implies hypersensitivity for criticism, anxiety, fears, unwillingness to communicate. No body is depicted, so there is no perception of yourself. And the second drawing, you can see the full body. Of course, this is not the perfect the picture, which also means that there is anxiety and aggression, but it already shows certain confidence and power and strength, and he wants to be a police officer in the future. So there is the vision of the future already in place. You definitely need to set the short-term and long-term objectives. What we do is we draw the staircase or ladder, and the upper ladder, upper level symbolizes the long-term objective, and then you have the steps in between. These are the transitional interim goals. It's easy to draw these stairs in the beginning and in the end, especially the long-term objective, but the steps in between are more difficult to identify. So it's very important to explain how important it is to be consistent, to take each and every step to reach your objective. And also, this is something that can be learned in the process of psychotherapy. You can consider the work completed when the teenager manages to find the ability to build the plans. I would like to show this drawing to you. This is not related to the case in question, but this was made by a 6-year-old child. The girl was recently brought for neurodiagnosis, but there is the organic complex of symptoms, among other things. So this is how the child drew the building, the house. You can see the fence going up, and down there it's the 2-level basement. I mean, there was the acute stressful event for the child, and it aggravated the condition of the child. And we can see this cluster of perseverances. And the mom says the child would keep drawing these similar drawings, like 30, 40 of them a day. So you need to work with the child. But there are certain barriers on this way. For example, to physically reach the session with the psychotherapist, there are dangers, the other obstacles. So, but they will take 2 sessions a week, even though it's so difficult for them to travel to reach our center, but still. So that's about it on my side.
Thank you very much. Thank you for this practical presentation. And I like really the questions because they're as well very practical, which means high relevance of the information. So, so the question is like, how many sessions you had with this adolescent so far?
With this teenager, we have had 8 sessions so far.
Mm-hmm. And second,
it's twice a week.
Mm-hmm. And second question is, doesn't painting of a family would be a trigger for those who has lost have their parents or relatives?
No, it is not. No, it is not. The child must face the situation real, not to imagine things. I mean, the trauma means that the child includes the lost relative or family member into the drawing, into the part of the family, waiting to see them again. And that's traumatizing. They must draw a family to be able to take the perspective of the child and to see through the eyes of the child how they see the situation at the moment. If this drawing includes the lost relative, the lost family member, that means that we have not processed the trauma.
Actually, Maryna is working face-to-face to children in her psychotherapeutical center. And I think this is a kind of very important issue, difference in therapy, face-to-face therapy and online therapy, especially with loss. Maybe you have your own experience or opinion, Maryna.
Я хочу сказати, я не тільки
I need to say that I not only work with children, I also work with adult people who lost their children. I work online with them. These are women from Mariupol. And that's why I can compare the difference. I can see the difference, and I can compare how the adult person, a mother, process the loss. And it's easier to work with a child with trauma than with the parents who lost their children.
з дітьми з травмою онлайн не працюю
So
зовсім.
I don't work with children with trauma at all.
Online.
Only face-to-face. I don't work online with children with trauma. I work with children online, but not with trauma. But I don't like working with children online, to be frank.
Dear colleagues, if you have any question or comment, because I know that here are as well child and adolescent psychiatrists and psychologists. If you want to comment any of the question or so, please do so. Please raise your hand. Please turn off your camera, turn on your microphone. And yeah, let's please share your experience. However, while we are waiting, there was as well a practical question in the chat, like what other exercises except the thermometer you can use to measure the anxiety, because many children, they don't know what thermometer is.
Це не обов'язково повинен бути термометр.
It doesn't have to be a thermometer. You need to depict a scale, for example, 1 to 10, and they could mark their condition on that scale. You don't have to compare it to the specific physical thing like the thermometer, maybe the ruler, school ruler, or anything that has a scale or can measure things.
And another important question, it was related to Dennis' presentation, but for sure we might have as well our insights. So it was related to group therapy with children. And the question is, does group therapy add trauma? For example, knowing stories of other children, or how to deal with that in group therapy?
Я не практикую такого.
I do not do this. I do not use this in my practice because I believe this could enhance the trauma. It is impossible to be definitive about this, whether you should or should not do this. You should select the children with similar types of trauma. I mean, I'm not doing this because I cannot bring children together. But if I did have this opportunity, I would try to bring children in a group who have experienced maybe like not same, but like similar, or I mean similar type of trauma, like losing family members, parents, losing the house.
Thank you. And Yeva Kardash, you want to comment or add?
Я б хотіла додати на рахунок груп, тому що
I
я
would like to add about groups because I do work with groups of adolescents. Sometimes it really makes sense to select children with a similar type of trauma, but it's very difficult to do this because the group is built in the beginning and children could have various traumas and different traumas. But I think it's more important to have children of the same type and character, and they help each other very well. For example, at about session 5, the group starts to move on itself. I'm sorry I don't have a chance to lead many groups, but children do need group sessions, for example, especially girls 12 to 16. I do agree with you because our center has always had group sessions for teenagers, for adolescents. They are very good at supporting each other. But so far, I do not have this possibility. I do agree with you that it's important for teenagers, but not for the young age children. I wouldn't go for that. It's the question. Please tell us the position of the neurodiagnosis. How do you understand that these were the birth or old data of a child, or is this the reduction of neurodynamics or the increase of perseverances because of trauma? How do you differentiate if this is the primary diagnosis? In that case, we talk to parents who talk to parents and then can say that this has never happened before, like exhaustion or reduced activity levels. And that helps me understand what happens to the child. But for example, they could say they have never had 40 drawings a day related to the basement or something, or no drawings at all. I mean, we are asking parents about the prior experiences. So we rely on their stories.
Yeah. Thank you very much, Maryna, and thank you very much to every participant and your important questions, which gives us as well insight which topics we should prepare.